I'm so glad to be with you. I'm so glad to have you here joining us. And what Jennifer tells me is we have over 30 people registered. So what I'm saying to you is I don't know who you are, and I know I want to say so much to you. We only have an hour and a half. I want to cover caring for the end of life, literally caregiving, caring about yourself, etc. at end of life. So there's so much to cover. And since I want to know who you are and all that, we'll get to that at the end. But Jennifer did tell you with the chat, please use that, because if you put something on there, we don't even get to address it. We'd love to have it. Why? We're thinking about doing a part 2. When? We have no idea. What exactly the topic, we really don't know, but based on what I've put together today, and we do or don't get to mention, and your questions, etc. Bottom line is we want to bring to you part 2 that would be the best that you would like to have done. I come to you with training, with experience. I've been a nurse, as Jennifer said, forever, and I have the blessing of being with many people through life and death, and that's from baby all the way out to over 100. And so I'm blessed with the opportunity to be with people from in healthcare as a nurse, to my own family members, to people that are my friends, etc. I've been designated as the go-to person for individuals who say, I can't be with my dad when he dies. I want you to be there. So I'm bringing to you a number of things that I have equipped myself with and been blessed to have. And I know that you have some of those things, but not knowing why you're here, I would like to share with you some of the origin of this information, not only schooling and all that, but LNEC, End of Life Nursing Education Consortium. I have put some of the slides that we use to teach LNEC. This is mostly for nursing, learning how to take care of people at the end of life and their families, etc. So again, that's part of my introduction to say I'm going to appreciate a number of people. Also, you heard Jennifer say that near-death experiences is a strong history of mine. I'm on the board and those kinds of things. What that is when you die and you have a light in the tunnel, in Jesus, for example, etc., and then come back. For whatever reason, after you were hit by the car, oh my gosh, you came back. So the person died for a little while and came back. I have a whole lot of expertise in working with people. And also in the city of San Antonio, I started a support group that was for people who either had a near-death experience or their loved one who, oh my gosh, was so involved before they died, etc. It was very successful here in San Antonio. And then I moved to Houston and there was one there as well. So besides that, I also started a support group for donor families. And what that means is people who died and at the end of life, they decided to give their organs and tissues, and or their family knew their wishes and they donated their organs and tissues. And what I mean by that is heart, liver, lungs, corneas of the eye, etc. So I started a support group making sure that those people were held to the attention that they needed and had, so on. So I put together the objectives for today, knowing that we all need to look at some of the roles that caregivers play in helping their loved ones, in helping each other, and helping certainly the person who's dying, etc. What kind of interventions might we have, might we do, etc. And those are all kinds of avenues we might go down, looking at psychosocial, spiritual, ethical, legal, etc., etc. So what you're going to hear me say is a whole lot about a whole lot. And so I want you to know that trying to make sure that we get this, well, where do I even begin? I can tell you I didn't know where to begin. So taking what Stephen Covey says is you always want to start with the end in mind. I don't know what you came for, as I said, but what's your end in mind? Did you come today because you have somebody in your family that is dying or just did? I just want you to know that we respect and honor you. If you're struggling right now through the loss of or through the really bad illness of, we respect and honor you. Don't expect you to say anything. We just want you to know that we care. So what is it that brought you here? What are your goals, etc.? I don't know if you're thinking right now, end of life for myself would be the best of the best. I'm telling my family about this, etc. I'm going to mention to you advanced care planning. So there's a number of things that are going to come into this presentation with starting, where do we even begin this situation. So I'll look at another thing that many of you may be with us because you've been working with Jennifer and Kylie and the team, looking at dementia and issues that come up with caring for people with Alzheimer's, etc. We've focused a whole lot of caring for the caregiver team work on dementia. I'm going to mention a few things about that. Maybe that's why you came. It was another program that we were doing on dementia, and you're absolutely right. But this is not narrowed to that perspective. It's a lot more global. So we've said to you in those presentations, family caregivers are the ones that primarily do so much. They have a huge role in making all the end of life care work with the planning and the care delivery, etc. And we know that looking at caregiving at large, over 80% of care is often delivered by family members. So maybe before you came today, you said, oh yeah, our goals with our loved one who's had an illness, an injury, etc., have been really to keep our family together, the dynamics of us, making our home really safe, very comfortable, having all kinds of strategies that we plan on working together and using those resources. That's what we've been doing. But you know what? Now we are working with Dad with his really demise. He's really getting a lot worse. So you know what? Now we need to focus a little bit different and look on the best of both worlds. That might be the geriatric care he needs. We're switching him to a gerontologist. We're going to look at perhaps oncology, oncologists, etc. Whatever Dad's situation is, what is it that we can help him with? Maybe it's that gerontologist. Maybe it's a lot of other people. Maybe it's curative care we've been working with. That person's still helping, but we're looking more at palliation, palliative care, and hospice, etc. So let's look at some of those issues. First, we'll start looking at, and I know Sharon told me earlier, don't talk so fast because, ladies and gentlemen, I know I can talk as fast as you can listen. So I'm going to try to slow down at times, and let's take this apart just that way. There's 4 trajectories in this picture that look at how people die. So the first one, what you'll see is everything is going along in time, and all of a sudden there was a heart attack, an injury, an insult to the body, etc., and the person dies. That's going along, die. Look at the next one. The patient may be having everything go along, and then all of a sudden something happens, and oh my gosh, things just start going downhill and going downhill, and then the person dies. The next one, number C over there, is the individual has something happen, and then, oh my gosh, it's better. What? No, it's not bad. Oh gosh, it's better. It's worse. It's better. It's, well, bless her heart. She's going now. So it went from all the ups and downs to finally she's at peace. And then also the last one you see with that individual. Now, we are not talking somebody that's 95, 105 years old. We could talk in this one, for example, that child of 4 just kept getting worse and more frail and got into that situation and finally died a peaceful death. So ladies and gentlemen, we look at the trajectories here, then we might want to look at, well, where do we go from here? In the old way of looking at palliation, palliative care, trying to treat those symptoms, what we were looking at, where it says up here old, we were looking at the prolongation. If you were looking at life, how we were living it, and then all of a sudden at a certain time, things aren't good. Well, okay, hospice, let's go. He dies. And I'm not making fun of that. I'm just saying that that's so much of how we had for such a long time, going, hospice, done. Well, the better way to do that is start earlier and look at progressive care, starting with everything's going fine. What? Wait a minute, there's a little bit illness. And then as we get older, the comorbidities we have, yep, that diabetes is getting in the way. That renal failure. What about that hypertension? All the other things that are going on. Well, you know what, ladies and gentlemen, maybe at this point, even though it's the life progression, and if things are going pretty well, we need to get some of that symptom management going on. And if you walk away here with nothing else except for palliative care is symptom management, that's it. And then we get into more care towards the end of life, etc. So that's what you see on this picture is early on, we get symptoms managed, palliative care. And guess what, ladies and gentlemen, hospice is going to probably come in earlier and appropriately, etc. So we're starting to interweave all the things that get done earlier to be able to get the person dying as well as the family, significant others, etc., into the process for the death. And then the aftercare. Bereavement, huge, ladies and gentlemen, absolutely huge. So I told you whenever I said palliative care, I'll give you more of a definition looking at the big picture. It improves the quality of life not only for the patient, but their significant others. And I'll tell you, when I say the word family, it's not, if you look it up, being related by blood, marriage, or adoption, how many of you have no sisters? But that person, oh yeah, she's the significant other. She's your family member. And so when we're looking at care of the individuals, what about those loved ones, family, however you want to face that. So looking at the problems associated with this situation, this life-threatening illness, injury, whatever it might be, and then trying to look at the prevention, the relief of suffering, getting in there early, identify it early, get some symptom management with impeccable assessment and the treatment. So we're going to figure it out and then treat as much as we can. And I want you to hear me talk about pain, 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 and more pain. If we had a long time, we could spend an hour on just pain management throughout life, but surely at the end of life care. So pain, looking also at other symptoms, looking at physical, spiritual, emotional, psychological, psychosocial, etc. So applying as early on as we can, looking at these things. Also, some of you might think, or when you've heard the word palliative care, hospice, and those words go together. They kind of work together, as you saw on my picture earlier. Unfortunately, people think that hospice and palliative care are the same. And hopefully you'll appreciate after seeing this picture I'm giving you, they are not the same. I can tell you that I lost my dad at Easter, the day before Easter this year, and he was in the hospital. And as a nurse who was working in the hospital, I said, I want him to be treated with palliative care. Oh, no, 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 we don't want to start that, because then they'll stop doing this, that, and the physician who I'm talking to at the moment is making hospice and palliative care the same. And I, the daughter, the nurse, am asking for palliation. I'm asking to treat my dad's symptomatology. He's not dying right now. He will. We don't know when, etc. But palliative care is what I'm asking for. It was not done. It was not something that my dad was able to have because he was thinking about hospice. So unfortunately, that was not a good outcome of that for our family. But looking at the differences here, when we think about palliative, I've told you it starts early, kind of goes throughout. And hospice, typically, wherever you are in the country / world, most people think 6 months of life left, and yep, let's go ahead and get her registered for hospice, because that's what we're thinking. Some people live 7 or 8 months. That's okay. I can tell you the tragedy, the worst part of all this about hospice. I had a woman tell me at Methodist Hospital very recently, her mother was on hospice care for 99 minutes. That is absurd. We should have them as early on as we can get that care for the patient and the family. But days, weeks, often you'll hear it's about 2 weeks, which is sad because I told you 6 months. Most of it should be started then. This occurs, palliative care anywhere, can be anywhere that you would like to have the patient or he would like to be. Hospice is typically, there are inpatient hospices in the city. There's one, and that's Vitas. And then many of the hospice organizations will go to homes, have in care in the hospital for a little while, etc., and then long-term facilities. So hopefully you can see a lot of that end-of-life care beginning way back there with palliative care and or hospice. Also, the palliative looks for curative care. Palliative really is more symptom management and moving into some of the situations where the patient is starting to not want that anymore, maybe not any more dialysis, anything that's going to prolong potentially even the suffering. So that's why we're looking at maybe backing off of that kind of care. So includes end of life, yes, for palliative as well as end of life care. What I'd also like you to see, many people don't know this, but in terms of palliative care, a lot of insurances and Medicare and so on are really not coming forward. I can tell you there's a whole lot of coverage for hospice. If you're looking at that for a loved one, hospice really does have, in terms of Medicare, Medicaid, third-party carriers, etc., funding. It's really wonderful. So on the whole picture, how is palliative care different a little bit, if you will, from good health care? Well, good health care is good health care, but what we're focusing on with palliative care is what are the goals of care? What do we need to understand to move forward with? Bottom line, y'all, It's the patient. It's the preferences of the individual. And you're going to hear that through the rest of my presentation. But what does dad say? What does mother want, etc.? Weighing all the risks and the benefits, looking at all this, and palliative care helps us keep a finger on the pulse, saying, okay, what we need to do now is look at it a little bit differently. Let's talk about, and so on, communication, comfort, and literally end of life closure. What does the individual want before she dies? Because you know what, and I don't know how much any of you have heard this, I am shocked in my nursing career to see that I believe patients choose when they die. And what do I mean by that? I've gone home thinking, bless his heart, he'll probably die tonight. 3 days later, he's still alive. What? As a nurse thinking, what is that for? His son comes from Arizona. He dies that day. That's all he wanted. He wanted to wait, and his life closure needed to have his son there. In other situations, doing so good, probably going to go home tomorrow afternoon. What? He died last night. That's not possible. He could, yeah, he was done. He was tired. So hopefully what you're hearing me say is people somehow or another, they die in very interesting times. So looking then to kind of close this part about palliative care, we're looking at, hopefully you've heard me say, processes, the way we put this whole thing together, and then individual pieces, the physical, psychosocial, spiritual, emotional, social, literally looking at cultural issues, etc. What about, where are they coming from in the world? Now they're in San Antonio, Texas. What can we do to help them with their expectations of self and others regarding their own culture? Maybe it is about their education, etc. What is it? How can we help individuals who are in the dying process, and especially ethical legal issues come up as well, which I'll mention in just a minute. If we all remember that dying is an individualized personal experience, we can't say anything about, well, it should be, and we could be, yes, perhaps we could be offering or doing or intervening in certain ways, but this is all a very individual thing. And one of my reasons for telling you that is because all the work I've done with near-death experiences, people have told me when they died and came back after the resuscitation, how incredible it was, and their whole life has changed because they're no longer afraid to die. So if you have somebody in your family that had a near-death experience after that heart attack that he had, and he arrested and everybody resuscitated, and wow, he made it back. And he's telling you, girlfriend, I'm not afraid to die anymore. I was always so afraid and I thought it would be suffering, but no, it wasn't. I'm back and I'm okay to die now. Well, y'all might think if this patient's 95 years old, if your loved one's 95 and you think, yes, he's finally going to go be with grandma, and we're really happy about that. And that lack of fear of death is, oh, wow, it's so good. I can tell you if it's your 4-year-old that says, Jesus wants me to play, the angels need me to dance. When that child was abused and died for a little while and was resuscitated and came back, that child experienced a wonderful thing as well in this situation. And now he's not afraid to die either. So what I'm telling you at end of life, sometimes, wow, for the caregiver, is it tough looking at these individualized deaths. So we're going to talk about our roles. And so if you just, this looks like a very busy trajectory here, but all I want you to see on it is we start at the beginning being aware, we need to take mom to the doctor, we need to do certain things to keep her going, etc. And as you go across this, more individual needs, more specific things, and then all the way out to, as you see in the middle part here, looking at a lot more individualized care, perhaps bathing her, perhaps having more people come in, etc. So when you look at the trajectory of knowing, after that, let's just call it the stroke, let's say something else that's going on with, oh, she fell, and all of those kinds of things, awareness, getting things done, it's not looking good. As it completely progresses, you're seeing things that now more and more required healthcare needs of your loved one that might be taking place, and then looking at end-of-life care across this board. So again, looking at our roles, if we completely think about what's going on a routine basis, helping that loved one with just the activities of daily living, what about their comfort, physical needs that they might have, and so on. So hopefully you're seeing this as kind of a summary, if you will, of all this. Excuse me, supporting their needs, supporting what they might want, supporting the people who are also caring for them. That could be real tough stuff. Also looking at the comfort and care, the dignity, the definitions of things they have: emotional, spiritual, as I said, physical comfort that they might have, and then also providing the best end of life care we can give them. Again, looking at across the trajectory, it might be that the daily routines, priorities, etc., are changing as the death nears, as we're starting to see things progress. Then maybe some of those goals we had to begin with are gone. The patient saying, I don't want this anymore. I don't want to have those people here anymore. I don't want to do this anymore. Can I have the priest? And they want to see the priest daily, not once a week, not coming to give communion or anything like that. But no. There's daily choices that are becoming more and more prevalent to this individual now. And so making sure that comfort of whatever needs are there. Also, we're going to talk about interventions. They need to be, in my opinion, they need to be absolute attention on pain and suffering, pain and symptom management. What is pain about? And so I'm going to spend a little time on that, because none of us really know what pain might be, because it might be totally physical. It could be some kind of emotional as well. There could be some other things that are playing into this pain. So what can we do? So perhaps having you, the caregiver, if you will, accept some caregiving tips, traits, as well as accepting it for yourself. So just acceptance of caregiving techniques, et cetera. Interventions should really be paced based on what's going with the individual who's dying. So maybe yesterday we did it like this, or today we should do it like this, but no, he's not ready for this. Absolutely no way are we going to do the following that we did exactly like this yesterday. And maybe that's even what the prescription says, but perhaps not today. It's not good. So let yourself be guided, if you will, by the process and what the individual is going through in this process of dying, as well as postmortem after the patient has died. And then bereavement support. All these interventions go from start to finish, if you will. Also, ladies and gentlemen, please pay attention to anything that changes from normal. Now, that might sound like such a bizarre thing to say, but if normally mom does this or that, everything from physically, could be anything from bowel habits, it could be something like eating, etc., like that. It might be other kinds of mood changes, things that have to do with connections of individuals, spiritually, etc. So anything that was normal, what's that really mean? Their new normal, etc. So looking at that. And then I told you we'd go through each individual thing. Unfortunately, we don't have time to spend on spiritual, emotional, physical, etc. But I'm just going to highlight some of these. And in this one, I picked cancer. And so looking at some of the aspects that we would look physically at cancer care and towards the end of life, we're looking at pain. What can we do about that? Can we do something that's about medications? Can we do something that literally would be an intervention of some kind of surgery or whatever? Maybe it would be something that would make the pain go away, but the patient says, absolutely no way. Example I will give you is a gentleman we told, and we need to amputate your leg. No way. Oh, sir, don't you understand? If we don't amputate your leg, it will make you die because your body will be totally infected, or whatever the case may be. And he says, hell no. I'd rather die with two legs than walk around with one. No. If I have to die because I'm not going to lose my leg, so be it. So his pain and suffering were all completely mixed differently now that this person told us no. What you're offering in terms of interventions and treatment, I'm not interested. So honoring that is certainly important. And then as we look at not only cancer care, but other end-of-life care trajectories, certainly dyspnea is one that we pay attention to: weakness, fatigue, delirium, anorexia, any kind of the bowel habit changes, vomiting, diarrhea, nausea, etc., skin breakdown. Once again, the more the individual is bedridden, you're going to start having those areas where they begin to be more and more acutely injured, if you will, in terms of their breakdown of the skin. And then maybe you'll have other problems really compounding that. So some things I told you I was going to talk about pain. And so looking at pain overall, the chronic pain, you're often going to see this, especially as the person ages. You're going to see musculoskeletal, low back pain, maybe things with osteoporosis, osteoarthritis, neuropathies, other kinds of things, cancer, constipation. Cancer, constipation, looking at spinal issues. So as you see people either aging and or their cancer, their illness, their injury going on, some of these things as they age might be persistent and get worse. So I'd like to talk to you for just a minute about myths. Believe it or not, these are real things that I didn't make them up. I don't have time to make up stuff. I'm too busy. So looking at pain, and people will say it's just a part of getting old. So people that are old are going to just have pain. That's unfortunate. Older people are not so sensitive to pain. So it's not probably that bad. If an older person doesn't report it, he's probably not having it. What? Just because he doesn't say he has pain. Many people are taught to not say they have pain because that's something that's expected in the family. Real men don't break down. Real men don't cry. Real men don't say that they have to have pain medication. How unfortunate is that? But you will see that. If somebody tells you that, oh, he can sleep, he can be distracted, his pain's not that bad. He doesn't really have pain because he can fall asleep through that. What a terrible myth that is. Also, some people will tell you that strong pain medications like morphine really shouldn't be used with older people because it's just too much potential side effects. It's too dangerous with them. Wait, what about that ongoing pain that's so bad? The patient is suffering, now not eating, et cetera, really doing very poorly because of the pain. And morphine could help. And we can do it in such a way that the patient can handle it just fine. So making sure that the patient is getting what he needs is appropriate, and stop thinking about he's going to get addicted. It's so sad when you see family members in the hospital say, no, you can't give my mother morphine because I know people who have got what? It's not about addiction. We are treating symptoms. We are treating the pain. We're not giving somebody something just to feel better, et cetera. So it's not about that. And also when you look at people who have dementia, people will say the person with dementia and other brain things, they don't really feel the pain. And people with dementia or other kinds of things like that, if they can't report it, then it's really probably not there. I hope you've seen all these myths that I've just told you. It's really sad, unfortunate, but people really think them. Also looking at some psychosocial things. What about people's beliefs and their values? What about the situations that psychosocially you're thinking about? If the person's saying, when I'm at a certain place, whenever I'm getting ready to die or whatever, my illness gets really that bad, who's going to really speak for me? Who should I tell what I want, etc.? What really makes life worth living? And personal, spiritual belief systems, how are we? So bottom line, you want to hope for recovery, surely. But what do we do, especially psychosocially? What kinds of things, interventions can we have for these individuals? Thinking about, for example, the social aspects of care. Family patients, they are often a unit. And I tell my students when I'm talking to them about nursing care, because that's what I do, is work with nursing students. And I tell them family and patient to me are one word. So whenever I'm talking about patients, certainly I'm pulling in not only the word family, but significant others. So we can classify them how we wish, but it's those people who are connected. Addressing the changes that we all have in our roles, because I've never done this much before for my husband, but now that he's in this situation, I'm doing it all. My roles are completely different. I've never paid the bills, et cetera, but yep, I've got to do that now. So in terms of, again, some psychosocial needs, it might be some kind of other people helping with the interventions, maybe a banker, lawyers, et cetera. Ethical, legal help, yes, you bet. So what other caregiving issues might be out there? I told you earlier I would mention advanced care planning, and I can tell you, ladies and gentlemen, it's the cornerstone of high quality palliative care. We need to know what somebody wants before it's necessary to do it. So literally helping them know, helping us know what they expect. And many people don't have advanced directives and that kind of thing. So when you get to the hospital, if they ask you, do you have any advanced care planning done? Do you have an advanced directive, et cetera? We have to ask that at the hospital. If people say, oh, what? Then they probably don't. If they don't know the terminology, maybe it's that, but do you have a piece of paper that tells us, if you can't speak for yourself, what we should do, et cetera? So that's the whole thing about advanced care planning, is early on, we're saying, okay, what is it that we can do? What do you want us to do in advance? So it's a formal situation where really we have it written down and so on. Also, in terms of looking at the picture like this, we want to make sure that we realize that older adults, just because they're older, and I don't know what old is, if you look at there's old, and then there's old, and I'm not making this up. There's certain age groups that fit with those, that old is a certain age. And so what does that mean? People can still make decisions, even though they might not say it exactly like we want them to say it. They aren't acting exactly the way we want them to act. It might seem strange, but they can still make their own decisions. They maybe aren't speaking the language we are, but I can tell you in healthcare, talking to my own family, I'll ask you this. Those of you in healthcare out there, does your brother know where his gallbladder is? Come on, let's be honest here. And looking at just something that sounds pretty natural, like a liver, a kidney, a lung, how many people can speak language of healthcare, much less their own language? So are we even speaking to them the way that we should to help them? If this, then that, in terms of your decisions. Also, if they're not very well educated, they really don't understand about that story about how the dialysis is going to take place, or what that pacemaker is going to do, or why she really doesn't want to have that pacemaker. At end of life, does she really need one? Why should she have one, etc.? So looking at the fact that the person may be handicapped or something else is going on, like they're deaf, blind, etc., they can still make decisions just because some of these things might be going on. Also, in terms of spirituality, I will say right off, there's some people that equate religion and spiritual as the same. So for example, some people say, children and adults might say that they're going to go to heaven. So heaven might be a place that is something that's related to Catholicism or their religion, or that's whatever. In our church, we believe this or that. And so you should have the last rites, you should have the priest come over, and etc. So some of those things are driven by actual religions and dogma and doctrine and so on. Other people will tell you it's really not about, I used to be a Catholic and I'm not a Catholic anymore, but oh my gosh, I'm so spiritual. I am really close to my maker. I'm really close to God. And at this point in time, I don't want to do my dialysis anymore. I don't want to do the things that they're asking me to do for those medications. I want to stop all this and I just want to go on. I want to go to heaven, or I want to be with my creator, or whatever. So it might be a word that they're using that really has to do with something that might be, once again, of a religious nature, maybe not. So please, in my opinion, please don't equate that spirituality and religion are the same, because a priest told me one time after his near-death experience, he said, what I've learned in this, it's not about the doctrine and the dogma that I've always preached and done. It's really about the real message. And I said, what would that be? And he said, it's about love and knowledge. And so love and knowledge is what this man wanted to go to his death with, and not worry about all the rules and the dogma, et cetera, et cetera. Also, when we talk about psychosocial issues, I just am throwing this slide out there because I want to remind us that many times there's issues with ethics. So in every hospital in this country, if you have Joint Commission accreditation, you have to have an ethics committee. What? Available to everybody. That means the patient, the family, the whoever can call upon the ethics committee. The janitor can do it, the nurse can do it, the visitor can do it, etc. So if we're looking at, should this individual be receiving this kind of care or not? Does she have the right to say she wants to have no resuscitation? We call that DNR, do not attempt resuscitation is another term, DNAR. So I can tell you in this country, but for those of you who are working with end-of-life care with perhaps your individual, your loved one, I would certainly ask about that. When my dad was in the hospital and the doctor asked me, my dad was perfectly lucid and capable of making his own decisions, but he was at that time really in pain and doing things that were, appropriate. The doctor asked me, okay, so if he needs to be resuscitated, what do you want us to do? And I said, whoa, 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 stop right there. This has nothing to do with me. This has to do with my dad. So let's ask him, does he want to be resuscitated? And let's talk about why and how, etc. Well, I can tell many of us, maybe in the audience as well as myself, at one point in time, sure, I want to be resuscitated, but maybe out here at this point in time, no, I prefer not. So if you look at what a person wants to have done with themselves, okay, what do they want and why? I can tell you the new term across the country, rather than saying DNR, which is do not resuscitate, it's AND, which stands for allow natural death. I had a doctor in a group I was presenting to, about 60 people, and she stood up and said, I will never call my patient or the situation DNR again. I appreciate what you just said about do not is not the right thing to say. And I love allowing natural death because that's what we want to do. So we want to stop, as I said, certain medications that are really tough, the dialysis, the other kinds of interventions that we're doing, they're causing more pain and suffering, and allow him to just die. So if he stops breathing, we're not going to put anything down his throat. If her heart stops, we're not going to smash on her chest. We're going to allow her to die naturally. So you see what I'm saying? Sometimes this has to go to ethics committees because the players involved, the physicians, the nurses, the doctors at large, consulting and so on, as well as the family, are all not agreeing about certain things. So perhaps it should go to an ethics committee about even surgeries, certain kinds of interventions that should be done at this time with this situation going on, the way this patient's story is progressing towards his death. So, and I'm also talking about children, et cetera. I'm not just talking about people that are 900 years old. I'm not talking about just older people. So the right to die is what I'm talking about. So I'm sure you've read many, many stories about this. The paper to the far right-hand side is one of the documents that are used in different hospitals and times and places. So if any of you are looking at ethical issues and things that might be in terms of advanced care planning, in Texas, we have 4 advanced directives. One has to do if you need somebody to cover for you when you're mentally incapacitated, that's one. But the other 3 are the ones I'm talking about in terms of advanced directives. That would be medical power of attorney, which is the person who speaks for you when you can no longer speak for yourself. And also some people call it the living will, which is really called directive to physicians. And that's a piece of paper that says, if I can't speak for me, this is what I want you to do. So it has on there specific things that if I am incapacitated, if I'm unconscious, if I can't speak for me, this is what I want on this piece of paper, as well as that person I just told you, medical power of attorney. And then in many states, there's out of hospital DNR. Out of hospital DNR. And this is often done with the physician. So for example, you take mom to the doctor and they talk about with you, obviously, that she does not, if she's at the grocery store, if she's at the ball game, if whatever, and she goes down, her heart stops, she says, no, I don't want to be resuscitated. And many people have an armband with the state of Texas emblem on it, etc. And so that determination, that distinction, if you will, is made between the doctor and the patient. And it's all certainly documented because the patient says, no, I don't want to be resuscitated. It helps the family so much to know that's what she wants because that's what she wants. So let's go with that. So I can tell you that there's a toll of the death and dying, not only on the patient, the family, but all of the caregivers that are out there. So the patient may fear what will be a physical situation going on and what about the financial burden. I will never forget the gentleman told me, no way, when we were talking about a certain intervention for him, it was going to be pretty costly. And he said, no, I want the money to go to my son's college. I do not want this to take my physical health. No, I don't. I'd rather die, but because my son needs this money to go to college, he's almost ready for that. So you can see some kinds of determinations that are hard, whether it be a person that's really older or the person that's, as I was just talking about, middle-aged perhaps. So also, what about when we say nothing more can be done? I personally believe that that's a crazy term. And in healthcare, I've seen more and more people feel the same way. There's always something we can do. There's always something we can do. We can honor the person's wishes in whatever way. It could be anything from no more visitors today. It could be, I don't want this, but I do want that. I can tell you that one of the most beautiful blessings that I had when my dad was leaving the hospital to go to the inpatient hospice, whenever everything was being signed off, the paperwork and so on, the nurse said to me, "Oh, hey, Deb, don't worry about the Dos Equis." And I said, "Excuse me?" Well, I had talked to the doctor earlier, a couple of days before, about when my uncle died in Dallas. He wanted two things, a beer and the dog. That's the two things he wanted. And the doctor thought that was so funny, etc. And we had just talked about it subsequent to that. So here's my dad being transferred from the hospital, from the inpatient hospital, obviously, to an inpatient hospice. And the doctor said, sure, he can have a Dos Equis. So he wrote the order that my dad could have a beer. And ladies and gentlemen, he did. Whenever he was in a really rough place in terms of his story in his healthcare, he had a beer and I handed it to him and I have a picture of that. So yes, and then also the dog. He doesn't have a dog, but my nephew does. And yes, in the room with my dad is a picture of the dog and my dad having a beer. So what I'm saying to you right now is, I know it might be a big stretch for you to think nothing more can be done. Yeah, it can. What does the patient want? Does she want her best friend there and nobody else? Yeah, she does. Does he want one more picture of such and such? Whatever it might be, think about you and your family member. What is it that you might want? What matters? What's logical? And what should we do in our roles and so on? So yes, just looking at those kinds of things, the spouses and so on. End of life considerations that you might want to make are looking at the care delivery, and that it should always, always, always be based on what the patient wants and the comfort of all that. What about how we are focusing on what? It should be all about what the patient helps us know based on what she can do or whatever. Hospice or specialized palliative care services are available. What could be available to us? We don't even know. It's looking it up, getting resources. And that's one thing in the next session, if we do part B, which we want to, part 2, we want to look at maybe some resources and giving you some ideas and so on. So also managing any kind of problems that might be out there, for example, feeding problems, feeding issues, and so on, considering that. What about infections? What about situations that we're bringing up that could cause infections or get him out of that situation that would reduce the possibilities of that? So looking at the clinical situation and so on. And then also hospitalizations, they can be very traumatic. Some people will say, I'll do anything but go to the hospital. I've had several people ask me, when such and such happens, will my dad have to go to the hospital? And the answer is no. I can tell you many people in the hospital, I can tell you as an intensive care nurse, say, I want to die at home. Ladies and gentlemen, I hope you heard me loud and clear. Many people wish not to die in a hospital. And it's unfortunate that as soon as they get really bad, we rush them to the hospital. And then even if it's in the ER, they die in the hospital, which is exactly the opposite of what they wanted. And I can tell you some parents want to take their babies, their children home to die because they feel like that's the loving place that they would want them to die. And that's what they would want for themselves. Also, when you have situations going on about end of life care, do they really need all the things we're doing? For example, medications. Do they really need those 3 meds? Because many, many people are on so many medications that perhaps they don't need. I know one gerontologist here told us when she sees patients the first day, she always asks them to bring their bag of medications and let's start looking at what we can stop. And many of you have heard that in our dementia work that we've been talking about too, is whenever you look at all the medications people are on, do they really need that? And do they need other interventions and so on? So we're going to move towards closing this presentation at all the totally dying well kinds of situations. And what are we thinking? We know that death is part of life. And, some people will say you can only die once. Well, you can only die and be gone and stay there once. But I can tell you from all I said about my work with near-death experiences, there are some people that have had more than one situation. One lady had, 3 situations across her her lifetime. She had a terrible, terrible situation with asthma. And so she thought when she died, it would be a terrible, choking, god awful situation. And she said, when I actually did, it wasn't awful. I didn't feel like I was drowning. It was an okay, safe place. And so I wasn't afraid after that. And then she had another really bad episode where she completely stopped breathing, had to be intubated, et cetera, et cetera. Once again, lost completely, pulseless, and so on, was resuscitated successfully. And she again said, it's not horrible. It's not a bad thing. So I'm okay being treated this way. So yes, death and life go together, but how that actually proceeds, what are opportunities that we have? What kinds of things can we learn? Can we grow? Can we do? Can we perhaps change the next time we're doing this? And so the profound personal experiences that people share, oh my gosh, I can tell you from doing the organ and tissue donor awareness and that support group that I was doing, I don't think I've ever learned so much from people just sharing about what happened. And many people came because they wanted to know when their child died, was it a bad thing? Because in the fact of donating the organs, their child had come to the hospital because of a terrible injury that they had. And was it something that they could make some kind of peace with, knowing how it was for other people? And also I can share with you, and when a person who talks to the family, when they get to actually meet, that I actually was working with a woman who got a heart from a 19-year-old. She was about 35, and she got a 19-year-old's heart. And when she visited, worked with the family of this individual, she got to meet them. The mother of the 19-year-old said, can I just ask you a huge favor? And she said, what's that? And she said, may I hear my baby's heartbeat? And so literally the person who received the heart allowed the mother of the donor to put her head on her chest and hear her baby's heart. So I can tell you that many situations like that at end of life are profound and something that certainly I'll never forget. I also think it's interesting when I tell healthcare providers, when I talk to doctors and nurses, teaching them about certain things regarding end-of-life care and looking at what is it that the patient and we think. So for example, good quality cancer care, for example, the healthcare team thinks it's when we're providing great symptom management, we're discussing all the emotional issues and what does a patient want. So we think that's really great stuff. But what does a patient say? When you ask the patients, what do they think is great quality of care? And they're saying things like, well, when I'm in charge, when I really have the control here and my spiritual needs are met and literally everything's okay, paid for. I mean, I feel like I've got everything under control and order, etc. And then I'm in a good place with my son and my cousin, and etc. So they're talking about their relationships. And so believing that their life's been good, that it had a good meaning, that's what they think is good quality care. Yeah, the medications and all those other things, the healthcare providers say, yeah, we're on top of the game. That's not what the patient says. So looking at that. So ladies and gentlemen, what are some barriers to good quality care? Well, maybe it's our failure to acknowledge the limits of our medications, of our interventions, of our therapies, etc. What are some limitations, and or what could we be doing differently about those choices and so on? Lack of training that some of us have in this. I believe there's probably a healthcare provider or two in this group, and I don't know why you came, but hopefully we're all trying to learn more and more that we can about this. So our own training, and then looking at hospice and palliative care services, as I told you, they're not understood well. And so if you use the term, like a nurse tells me, she asked the doctor, could we go ahead and start Mrs. Smith on palliative care? And the doctor says, she is not that bad. She's not dying. And the nurse said, I never said anything about her dying. I said, and so it's almost like my dad. The situation is not about hospice, it's about palliative care. So what are we going to do with rules and regs and those kinds of things? And so that's another barrier there. And then denial of death. Oh, it's not that bad. Oh, she's not dying, etc. And in fact, the patient will tell you, oh yeah, I'm dying. I'm amazed at how many patients will tell you, you know, I probably won't be here at Christmas, or I probably won't be here next week or whatever. Well, why do you say that? I just feel that way. And so they're telling you exactly what they think. So issues, and I don't know if any of you ever heard the term nearing death awareness. That's not near-death experience, nearing death awareness. And that's whenever, let's just say mom's been in coma for 2 weeks and she's really not doing well and she's really going, etc. And everybody's come and they're sad and etc. And all of a sudden, mom wakes up and she looks around the room and she starting to talk to individuals who you don't see them, they're not there. And Uncle George has been dead for 4 years. And there she is talking to Uncle George, her brother. And you think, what? Well, that's because she's having a nearing death awareness. And very shortly after that, she dies. Ladies and gentlemen, this is not unusual at all. So when you're talking about a final rally, some people say, all of a sudden he just woke up and he sat up and he was doing great and then he died. Believe it or not, that's not unusual. It happens all the time. And I think people probably in the older age see it more because they're getting ready and they're there and so on. But I can tell you it's also happened with babies and children. Literally, all of a sudden, probably the most profound one for me, when I talk about end-of-life care, this is just such a stretch that I just love telling. But one of the nurses I was working with said that she was working with a baby, a child baby that was literally, I think she said probably 6, 8 months old, something like that. And the child was in coma and not doing well and in the crib being taken care of very appropriately. And all of a sudden, just like I was telling you about the patient over there, this child wakes up all of a sudden, and if you've ever seen a baby pull himself up on the side rails of the crib, pulled up, completely up, and stood there and all of a sudden put hands up like babies do when they want you to pick them up. This baby put hands up, hands up, hands up, closed eyes, laid down, and died. So I'm not sure what that was about, but that baby knew something that maybe nobody else could see or whatever, but in fact, that baby had a little rally too. So symbolic language, when they're talking about, I want to go home, I can tell you, since I've been an ICU nurse most of my life, when people say they want to go home, they often don't mean on 4th Street. They mean home, home to heaven, or wherever the hereafter is for them. And that's what they want to do. Now, some people will say, I want to go home to die. That's a different story. They really do mean they want to go to Main Street. But other people who say, no, I'm done. I want to go home. And that's where they want to go, is to death. And that's fine. Also, they have, as I just told you, they have visions. And that's what I was talking about. They see somebody out there, perhaps God has come or whatever the case may be, but visions. All right, there's an inability to let go. So what is it the patient's holding on for, or we're making them hold on for, or whatever. So saying goodbye might be hard. So maybe in another language of that, Mom, what would you want us to do if you weren't here anymore? And having a story or kind of a situation like that, maybe going. So also, ladies and gentlemen, I'd like you to remember that there are definitely consequences of caregiving. Wow. Do you get tired? Some of you who have been in the programs, LST and so on with us in the past, looking at caring for the individual that you love and who has dementia, etc. Wow, are you tired? Haven't had your hair done in 4 months, haven't been to church in 2 months, etc. Wow, that gets tough. We've talked about those situations. Well, the same thing can happen here when you're caregiving at end of life. You kind of don't do certain things for yourself, etc. Certainly sleep deprivation, not eating right, etc., etc. So some of those things that you are used to doing, like exercising. Oh yeah, you usually walk a mile a day, but no, haven't done it in 3 weeks. That's hard on your body. So staying in bed, trying to be able to sleep, etc. So what kinds of things, excuse me, are getting in your way of taking care of your own health because you're in the end of life situation. Also, I wasn't sure exactly how far to go into the actual time of death or when the actual death was occurring, but I can tell you that many people don't understand. And I can give you a great example of a student nurse that I had. And I said, have you ever been in a death before? No. Have you ever, your grandmother's never died? No, nobody in your family, no extended family, no. Oh, no. Okay. I said, have you ever had a puppy that died? Yes, ma'am. Can you tell me about, oh, she started crying. And then she started telling me about, it almost sounded like the individual who's a person has kind of a frothing. She said he had kind of this bubbling, I don't like spit coming out of his mouth. And I said, did you try to feed him? Oh, no way. Okay, that's good. We're not going to feed individuals whenever they're dying. And then also, did you try to make him have any liquid or no, he wasn't ready for that. He didn't want to lick, or he went, okay. So what you just described is what happens with a human. We stop giving them fluids. We stop giving them food. We try to do the best we can in loving and caring for them, making them as comfortable as possible. And she said how helpful that was to her, because she'd never been in a death before of a human being, but she could certainly relate to the puppy and how that worked. And why did I even bring it up? Because she had been working with a family who said, you people are starving my dad. I can't believe you people are making my dad die. And really, he's going to be dehydrated, and etc. And so if we healthcare providers would explain to individuals, if we stop doing those things, it makes the pain go away. And if for those of you who are in healthcare, if you explain as azotemia, where your brain really doesn't get the information about it should hurt, the pain goes away, and we allow, just like the puppy, to be loved and held and comforted until they die. And we are not feeding, or if you want to call it watering, anymore. We're just being kind. So at that time, when you're looking at what's going on, how do their pupils look, what color? I mean, some people say that blue lip kind of thing. Okay, that's when you have decreased circulation to the parts of your body, your hands start getting perhaps cold and mottled, et cetera, et cetera. So respirations, body temperature, all of that changes so completely. And then muscles start having different relaxations, tightening, et cetera, et cetera. So looking at the actual time of death may be difficult, but being there and trying to support whatever it can be would be great. Also, I can tell you that I was shocked at how many people know what we do with people after they die. For example, I was taking care of a patient, and her husband died. It was after he had had open heart surgery. And so the doctor and I told her that her husband had just died. And she cried and cried. Of course, I stayed with her. The doctor left. And I said, is there anything we can do to help you? And she said, girl, I just like to, could I help you bathe him? And I was like, wait a minute, what? And I didn't know people knew that we bathed individuals. And I said, well, and I wasn't taking care of him personally. I was the manager of the area. And so I said, oh, yes, ma'am. Absolutely, you can help us bathe him. I will come and get you in just a few minutes when we're ready to do that. I felt like it was exactly the right thing to tell her. However, I went back in and I told the nurse that was taking care of her. And she said, you told her what? And I said, she can bathe her husband now that he's died. And she said, well, you should have asked me. He's my patient. Well, no, he's her husband, not your patient. No, but I'm just saying that it was a rough time for her and I, because we disagreed. And so she was angry with me for telling the wife that she could bathe her husband. So what I said to her then was, okay, if you're not happy with my decision, that's okay. Besides myself and her, if you'd like to help us bathe him, that's fine. But I will bathe him with her. Because, ladies and gentlemen, this woman and her husband just had their anniversary of many, many years. And so she had no idea she was going to leave her husband to death then. And she did. And she wanted to bathe him with me, and she did. So bottom line is, what is it that we do at the end of life following the death? In hospitals, those of you who know, we do things like take them to the morgue, body bag, we send them to the mortuary, whatever it might be. And so do you know if it's your loved one, do you know if they want to have burial? They want to be cremated? What exactly do they want? And I can tell you, I am so blessed. The fact that my dad was lucid and very fine and etc. until it was time for him to die. I got to ask him, do you want to have CPR? Do you want to be cremated? Do you want to be buried, et cetera, et cetera? And so I did everything that he asked me to do based on our discussion about what do you want. So at following the actual death, what care we deliver, hopefully it's based spiritually, emotionally, culturally, et cetera, on what that individual wanted. So talk about it, and listen. Remember, ladies and gentlemen, listen and silent have the same letters. And so when you're listening to them tell you what they want, be quiet. Don't be telling them what they're supposed to be saying. Listen to them completely. So if you're there for the time, I mean, literally prolonged time, what you might see is the person gets kind of stiff, the rigor mortis sets in, and then there would be going to the funeral home and so on. So I can tell you that one of the most positive things I've seen, and especially working with funeral homes and mortuary folks, is aftercare. bereavement care, follow-up care. And I can tell you that many of the hospice organizations do beautiful jobs with the aftercare programs that they have. And I would highly recommend looking at that wherever you live and whatever situations you'd like to have based on that. So wrapping this up, I want to just remind us that in terms of a death vigil or whatever, having the family, loved ones, significant others there, and knowing some of their common fears, being alone with the individual, that they're not knowing exactly when the death occurs, that they're scared, that they're maybe a painful death. So helping the individual prepare for this vigil would be really nice. Also remind us all that if we hope for the best and prepare for the worst, that would be good. We want to make sure that we review all the treatments, do the best we can, and we don't want to prolong life suffering. What we want to do is extend the life as much as we can in a positive way. So we want to set up ourselves for the best and that the patient would have all we can do for them, and then prepare for the worst. If we don't know what to do, what can we do? Okay, so is there anything that should be done? Anything that's left undone? What decisions should be made, etc. So aggressive therapies such as DNR, that would not be a good thing. I've already talked to you about that. Some people have resuscitation against their own wishes, but because it was never an order or whatever the case may be. And so that's not a good situation when a person goes through that and they never wanted it, or the staff never wanted it as well. So, okay, so I'm going to start wrapping up and ask you if you have questions and so on. So I want you to remember that that you matter because of who you are, and you matter because I can't read for sure. Yes, I don't want to leave anything out. That you matter for the last moment of your life, and when we will do all we can, not only to help you die peacefully, but live until you die. Live until you die is the point I was trying to make there. So I'm going to thank you and ask you what questions you have. And for caring for the caregiver team, I'm going to say thank you for allowing me to do this. So Jennifer, this is the part where we're going to take questions.